It's my great pleasure to welcome you all to this 9th Impetus International webinar on Sudoscan. First, it's my great pleasure to moderate this session focusing on this breakthrough technology that I had the honor and chance to conduct a 3-year thesis on it a long time ago. For the first time, our webinar will cover the practical way and challenges to optimize the use of Sudoscan by addressing mainly the painful cases that have a big burden, as you know, on the quality of life. So what was best for us than inviting Sudoscan users, expert in neurology and chronic pain field from different geographic areas, to share their experience on Sudoscan and on how Sudoscan helped them in a practical way to better manage their patient and the challenges they have faced. Next slide, please. Precisely in the first part, Dr. João Martins from Portugal will highlight the challenges of the first experience with Sudoscan in a private setting in Portugal and how Sudoscan improved his patient management. In the second part, Dr. Mario Barmaki from France will present the clinical value of Sudoscan in chronic pain conditions. And the last part, Dr. Bobby Varki from India will focus on the latest update, the diagnostic and management criteria, in addition to the role of Sudoscan in fibromyalgia. That is, as you know, one of the conditions that are not fully understood and involve widespread body pain. By the way, this month is the month of fibromyalgia awareness, so was the best moment to deliver this presentation. I will not take longer and pass it over, next slide please, to Dr. Martins. He's a fellow of European Board of Neurology. He is specialized in EMG and neuromuscular disorders. He has held key roles in Portuguese neurological societies and now is working in private healthcare focusing on neurology and clinical neurophysiology. As earlier mentioned, Dr. Martins will focus on the challenges of the first experience of Sudoscan in a private setting in Portugal and how Sudoscan improved his patient's management. Dr. João Martins, please go ahead.
Thank you very much. It's for me a great honor to be here to present this presentation, and kind thanks to Dr. Anaïl for the invitation. So next slide, please. I will talk about the Sudoscan in Portugal and to make an overview and to tell about some the initial troubleshootings I had in this 6 months experience. And then I will talk about some clinical cases that were very interesting for me, and I will present 6 very short clinical cases to exemplify. Next slide, please. Portugal, as you may know, it's on the southwestern region of Europe. Next slide. It's next to Spain. We cover an area of 92,000 square kilometers, a population of 10.4 million. We have 60,000 doctors in Portugal with a ratio of 1 doctor for 173 persons. More or less in Portugal, it's the public system is divided in the public health system, a little bit similar to the British one. It's inspired by them. And now we are having a growth expansion of the private system of healthcare. Next slide, please. At my house, we correspond to this percentage. My wife works in the public health system. She's an internal medicine doctor, and I'm a neurologist, and I work in the private setting. So until now, Sudoscan was only available in 2 major hospitals in Portugal, one in Porto, Sant Antonio, and one in Lisbon, Santa Maria. And it was used mainly for investigation purposes of paramyloidosis patients to check the clinical involvement, and of course in the mutation carriers to check if they have clinical involvements and autonomic dysfunction, and to check the response to treatment. So it wasn't readily accessible for the general population. So there's an unmet need in Portugal to get to this innovative exam. Next slide, please. When the open marketing occurred, as far as I can tell, in 2024 in Portugal, in Neurology, Gregorio Leal is the reference member person of the company that talked to me. And next slide, please. For me, it was very interesting to have this exam. So I'm an electromyography, specialized in neuromuscular conditions, and for me, of course, electromyography is very important because it can detect central nervous system dysfunction when we find poor voluntary muscle activation. We can study the muscles to check if they're pathologic, if myopathic or neuropathic pattern. We can see the neuromuscular junction disorders with presynaptic and postsynaptic disorders. And we can also, of course, study the nerves of the large and medium fibers to check if there's sensory or motor neuropathy, axonal or demyelinating, focal, multifocal, or diffuse. But our Achilles tendon in electromyography is a small fiber pathology. We cannot detect. So, next slide, please. For me, it was a perfect match to have to make electromyography and have the opportunity to also study the small fiber pathology with Sudoscan. So it's of enormous relevance for peripheral nervous system neurophysiologists. It's my opinion. Next slide, please. So I work in the north of I live in the north of Portugal, in Santa Maria da Feira. It's a small city, little bit south of Porto. But I also work in several institutions of CUF. It is the major and oldest healthcare network in Portugal. They have more than 41 healthcare units across the country. So I had to, and Sudoscan is not easy to transport. It's usually it's not intended. It can be transported, of course, but it's not easy. Next slide, please. For me, it made sense to transport to the other units to get to more population, of course, and in the same places where I perform EMG. So in one volume only, for me, it was very heavy to transport. So I managed to have this special bag. I made it especially for this, to transport the metal plates, and it's easier for me to transport now. Next slide. One thing I realized is that you have 6 different automatic interpretation messages that I like very much. They are very, very nice because it's easy to have the results with the automatic messages. But I had to translate it to Portuguese. They didn't have this this version yet available. And there's an inadequate, I realized that there's an inadequate reference to diabetes, because they say for patients with diabetes mellitus, the test results may indicate the presence of distal symmetric polyneuropathy. Well, it's not true, because it can also happen with many other diseases. So, and this would influence only for the diabetic population, and it's not. So I took that off. When asymmetrical, the side is not referred to, and there's no reference when the affected limbs are superior limbs or inferior limbs, or the superior and inferior limbs that are affected. So I realized that there's a frequent need to write additional comments besides the interpretation automatic messages. This next slide, please. So the way I managed to do that is to add Bluetooth keypad and a mouse. And for me, because touch screen is nice, but it's not quite comfortable when you need to write some more, and to write some recommendations and all that. And well, I like to write, so for me it was necessary to have a keypad and a mouse that I added, and it facilitates very much the job. Next slide, please. So when I had the machine, the first thing I done is to test it on myself. That's obvious for me, and I to check if it was consistent. The results were consistent, and how they say there's a variation, very, very slight variation, less than 5%, more or less. I took it the first time at 8 o'clock in the night, and 1 hour after, the results were mostly the same, with very low, a very low difference. So it was very consistent. And I tried also 24 days after, in the feet, they were very consistent, but surprisingly for me, the hands, they had a majoration that I couldn't understand. There was an increase on of course in the green area, but it was an increase. So why? Well, I may explain it later on during a case that I will show you. Maybe there are other explanations, but this I have one that can fulfill it. Next slide, please. So I also checked it in healthy volunteers from the family, from friends, and from co-workers. I had more than 10 exams to check if to gain experience on one side, and also to check if the results were consistent, and the results were all next one, please, were all normal. And so I decided to try it on patients, and this was my first patient on the 11th, 26th of last year. And next slide, please. She was a 56 years old female, normal body mass index. She complained of feet paresthesia, not always present, and a left leg sciatica. She had a normal EMG and no other medical history relevant. She was on gabapentin and sometimes ibuprofen. You can, next slide. So this first exam was normal, so not a surprise for me. The complaints were mild, so it was normal. So another normal exam. Next slide. The second time, the second case I am going to present you is a 76-year-old male, and this is the very, very slim, very fit patient, and he came due to feet discomfort, nocturnal heat, pins and needles in the feet. And this is the first patient I had with type 2 diabetes mellitus that he had 2 years ago. And he had also a normal EMG. He was on metformin, 850 milligrams once daily, and pregabalin. Next slide. On this first patient that I had with diabetes, I got the first abnormal exam. And that was also reassuring for me, because the Sudoscan detected in the first patient with consistent clinic and history, he had consistent reduction of the pseudomotor activity only in the feet, consistent with a length-dependent diabetic small fiber polyneuropathy. So this was very reassuring for me. Next slide, please. The third case I'm going to present is a 72-year-old male. He's very fat, 36 body mass index, and he complained of pain in both feet. Very difficult it was for me. It's very difficult to distinguish between neuropathic and orthopedic or rheumatological origin or a mix of both conditions. It was very different, very difficult to ascertain. And he had only high blood pressure, and he had no AMG performed before. He was on antihypertensive medication and paracetamol sometimes. Next slide. And surprisingly, he had a normal exam on both feet and hands. So no pseudomotor dysfunction, no autonomic dysfunction here, no small fiber evidence of neuropathy. And next slide, please. But I asked for the cardiac autonomic neuropathy score in this patient. And the thing is, it came with a moderate dysfunction of the cardiac autonomic neuropathy score. So for me, it was quite surprising. And I talked to Anna Ayub, and they told me, well, the CAN algorithm is based on pseudomotor test result plus age plus body mass index. So he's 76, so, and he's very fat. So of course, it's normal to have this score because it's an algorithm. Next slide. But it made me think also. Next slide, please. Yes. It made me think because it raised some questions to me. because is it plausible to say to a patient that he has high cardiac neuropathy risk when he came to perform a test for pseudomotor function in the limbs whose results came to be normal? And should Sudoscan present those scores when limb activity is normal? And should we even compute cardiac autonomic nephropathy scores in the non-diabetic patients? So I don't have a sincere or honest response to this. Maybe we can discuss it in the discussion part of the presentation, but maybe someone with more experience can talk a little bit about this. Next slide. Then the fourth case is a male, a 44-year-old male, a little overweight, but not very much. He came with a tingling sensation in both hands and feet, and occasionally electric shocks in lower limbs. He had a medical history, bulky arachnoid cyst that presented from the cervical region C7 until the lumbar region L2 with spinal cord compression. He had no MG performed previously. He was on pregabalin. Next slide. And interestingly, he showed the typical pattern with the upper limb reduced pseudomotor activity and lower limb normal pseudomotor activity. It was a typical pattern. But next slide. As you can see, maybe this is explained by this bulky posterior extradural cystic lesion from C7 to L2. It's compatible with arachnoid meningeal kyst. And as you can see in the red arrows, there's different images, but the red arrows show the bulky arachnoid kyst, and the green arrows they show a very thin, slight and compressed spinal cord due to this arachnoid kyst. So it may justify the results in this patient. Next slide, please. The fifth case is a 24-year-old male, very thin. He came for very unspecific anomalous tingling sensations on both feet. He had a suspected rheumatological autoimmune pathology in the last 2 years with an ANA titer of 1/320 and a normal ENG. It was on venlafaxine and clonazepam. For me, the way I looked at the patient, I was not at all convinced that he had peripheral nervous system dysfunction. For me, it could be or psychiatric or rheumatologic or something else. But I was not convinced. And then you have a normal exam, normal reflexes, and for me it was very, very strange. But well, we performed the Sudoscan. Next slide, too, please. And he also had this atypical pattern of upper limbs with reduced pseudomotor activity and lower limbs with normal pseudomotor activity. But I was not comfortable with these results. I was very, very surprised by this, and I thought, what can I say? I'm reporting this. Am I reporting that he has upper limb reduced pseudomotor activity when he came with lower limb dysfunction, and clinically, nothing would believe that. I wouldn't believe this. So I decided to repeat the exam. Next slide. And so this was not clinical consistent. I repeated the exam. Next slide, please. And an error message occurred of movement. And so did the patient move his hands? I asked him, did you move your hands during the exam? Next slide, please. And then that's when I noticed that the fingers were not correctly positioned in the plates. And he told me that he had a difficulty. He had some kind of contracture in the fingers, that he couldn't extend the fingers very well. So he had to make an extra effort to put the fingers on the plates. So I realized this could be the problem. So I asked him to put correctly the fingers as much as possible, and then I repeated again the exam. Next slide, please. And now it works perfectly with a very normal score in the hands. So this is the same patient, and it was very, very for me, reassuring to check that the problem was technical, not of the machine, and it was once more consistent with the clinic and of my opinion that he shouldn't have neuropathy. Next slide, please. But apparently, it is just for fun. It may be a common error of the poor finger position, because this invitation, as you can see, the people that photographed this also didn't put quite well the fingers in the metal plates. Next slide, please. And I want you also to alert for this, because the diabetic population is very common to come to make to have the Sudoscans, and we have to notice that there's this sign, the prayer sign, that occurs due to hand stiffness and limited joint mobility, finger flexion contracture. That is the cheroarthropathy that is very common in the diabetic population. Up to 30% may have some degree of cheroarthropathy, and it's more frequent in the juvenile onset or insulin therapy and the longer duration. We have here two patients with published, one with a young girl with type 1 diabetes and a 52-year-old man with type 2 diabetes, badly controlled. Next slide, please. And this is my final case, male, 34 years old, a little bit excessive weight. He came due to severe distal weakness and neuropathic pain in the left leg and sensory dysfunction in the left leg, post-trauma. He had a motorcycle accident 11 months before in Switzerland. He had lumbosacral osteosynthesis surgeries in Bern, and surprisingly, he didn't bring any medical report. He didn't bring any exam made in Switzerland. He flew to Portugal for a second opinion, a second very blind opinion, because he wasn't getting better after 11 months of physiotherapy, and he wanted to know why, and because he couldn't understand it very well, or there was some kind of problem with the communication. And on medication, he was only on pregabalin, 300 milligrams, high dose pregabalin, twice a day. And he couldn't recall the other drugs, so he came more or less with nothing to tell us. But he was observed in orthopedic consultation, and they asked for the Sudoscan and electromyography. Next slide, please. And as you can see here, he had a pressure ulcer on the left foot, and these autonomic signs and muscle atrophy. You cannot see very well the atrophy because of swelling, but he had the leg, the foot and the leg with atrophy, with evident atrophy. And the pressure also because, of course, of this autonomic and because of the dysfunction of sensitivity that he had. Next slide, please. So I performed the Sudoscan, and as you can see, he had a very, very low pseudomotor activity on the left leg, on the left foot, and of 12 microsiemens. That is very, very low. Next slide, please. And the electromyography that was performed by me, he had the motor nerve conduction studies and sensory nerve conduction studies on the left leg with severe dysfunction, mostly distally, but also in proximal nerves. Next slide, please. And needle electromyography, it shows a plexus lesion, of course, a plexus lesion with L2, L3, L4 fibers with moderate chronic inactive axonal lesion, and the L5S1, S2 fibers with no activation and innervation both in proximal muscles like gluteus maximus, gluteus medius, and distal muscles innervated by the sciatic nerve. So he had a plexus lesion with no doubt, and this is severe with some probably a bad prognosis, and that's why he wasn't getting better. That was the explanation. But next slide. As you can notice, yes, and I'm showing the surgery, and we took also a CT scan to the patient, and we managed to see that he had the osteosynthesis screws in iliac, sacral, L5, transpedicular, and retrovertebral bars, and the left sacral fracture that was not aligned, and explains, of course, the plexus lesion. So, next slide, please. The thing is, besides the left dysfunction, pseudomotor dysfunction, as you can see, he also had reduced pseudomotor activity in the other 3 limbs. And that was quite surprising for me. I was very struck with this information. I couldn't quite well explain it. First, I thought, next slide. Next slide. I thought of this, an article, it's a very nice article by the Mayo Group Clinic, by Nathan Staff and James Dick. I advise you all to read this article because it's absolutely fantastic. It talks about post-surgical inflammatory neuropathies. And they state that not all post-surgical neuropathies are mechanical, and inflammatory mechanisms can be causative, presenting as pain and weakness in a focal, multifocal, or diffuse pattern. Even very small surgeries like dental procedures can cause post-surgical inflammatory neuropathies at a distance. And could this or a similar mechanism cause diffuse small fiber neuropathy in this patient? So that was my first impression, and I needed another opinion. So next slide, please. I talked to Dr. Anna Ayub, and he suggested me, well, it can be that, but I've never seen. And what is the medication he's taking? Well, I didn't have the full medication. He was only on pregabalin. But Dr. Anna Ayub advised me to call the patient, and I did it, to ask the full medication. And he was taking all these medications. And as you can see, I put it on red. He was on pantoprazole and oxycodone. The other medications are quite innocent in terms of pseudomotor anticholinergic activity. Next slide, please. But as you can see, there's a site where you can calculate anticholinergic burden for a patient. And here I noticed that oxycodone has a score of 1 and pantoprazole has a score of 1 on anticholinergic activity. It's interesting because if you put esomeprazole, it is another pump inhibitor, proton pump inhibitor, it would be a score of 0. So in the same class, there are medicines that can have anticholinergic activity and others not. And it's a very nice site to visit and to check the medications in the persons and in the patients that are going to have a Sudoscan, because this patient had a total ACB score of 2, and at least some part of the reduction of activity in the other 3 limbs may be explained by the anticholinergic activity of these 2 medicines. Next slide, please. And my final remarks are that, well, I realized in this 6 months of experience that Sudoscan provides very reliable and clinically consistent results. It's due attention is needed for finger position. Please check for the prayer sign, especially in diabetic and rheumatological patients. Always check the patient for full medication for anticholinergic activity. You can browse ACBC calc to calculate anticholinergic burden score. And my opinion is that Sudoscan is not an operator-independent exam, and clinical electrophysiological correlations of test results is key. Thank you very much. The next slide. Thank you very much for your attention, and it was a pleasure to give this lecture.
Thanks a lot, Dr. Martins. Congrats for this very nice and interesting clinical cases that you showed us. They were very interesting, of course, and the explanation you provided. Just for the 3 points that you have raised, first, for the interpretation messages, certainly will take into account your suggestions. Second, for the remark concerning the photo used for how to place the hands on the electrodes, Yes, it's a good remark. You are the first one to raise it. Thank you for this nice remark again. For the can score, I agree with you. So if someone don't have the ESC of Sudoscan is normal, and only the fact of having increased BMI and age, as you know, foster increasing the risk of can. This is in this situation. Usually, what is recommending is only pay attention lifestyle change. For next presentations that will be delivered by Dr. Mario Barmaki, a leader and expert in chronic pain management. He's currently the head chronic pain center and support care unit at Medipôle Hôpital Mutualiste in Lyon. In addition to his role as head of department, he's also a lecturer at the University of Lyon and coordinator of division unit in medical hypnosis. He authored several books and co-authored a number of articles on pain and supportive care. He will focus today on the role and clinical value of Sudoscan in chronic pain management. But before the presentation, I would like to pass my sincere condolences to Dr. Mario Barmaki for the loss of a very close relative of him, and to heartily thank him for joining us to fulfill his commitment to be with us despite this very unfortunate situation. Thanks a lot, Dr. Mario, for that. This means a lot for me and for all Impetus team. Thanks a lot. Please go ahead. We are proud to have you with us.
Well, thank you very much for having me on this international webinar. In fact, yes, my father passed away a few days ago, and I would like to thank you, Dr. Ayoub, for your kind thoughts. And I have promised to participate, so I will stay to my commitment. I would like to present to you the return of experience of a chronic pain center. Although we don't have a very large and in a short while, we have the Sudoscan. It's almost been a year and a half, so we have a good experience now, and I think we'd like to share this, and we will hope to share with you this presentation. Next slide, please. Neuropathic pain in our daily assessment pain is something that is very frequent. It's more than 85% of our patients that present neuropathic pain. It's very common, but yet it's not always precisely identified and sometimes difficult to evaluate. We are not brilliant neurologists, just like Dr. João Martins, so we have the use of neurology every day, but we are not always very qualified to identify the infraclinical signs of the beginning of a neuropathic pain. So it includes the fact to know exactly that small fibers, the C and A delta fibers, are the peripheral pathway for pain and thermoalgic signals to central integration. I will not go further on the physiopathology because we only have 15 minutes, and during these 15 minutes, I would like to transmit the maximum of information. Next slide, please. What are the patients and who are the patients that we see most commonly? Well, it is very diverse because pain is the only common thing between all these pathologies, and I think that it's absolutely not exhaustive. I think it's even not exhaustive at all. Well, the most situations that we see are severe diabetic neuropathy, the post-chemotherapy neuropathy, especially with cisplatin, taxanes, Velcade, vincristine, and all the other toxic drugs. We have the neuropathy of the paraneoplastic syndromes. We have the new patients, the long COVID patients, the Fabry disease, HIV, hepatitis C, alcoholic neuropathies, amyloidosis. Even it's not very common, but we see them also. The Gougeot-Sjögren disease, the lupus, the neurologic severe affections, multiple sclerosis, Guillain-Barré, and a lot of more. But we'd like to, and we'll take as a model, the severe diabetic neuropathy and the post-chemotherapy. Next slide, please. Well, we are we stay very tuned to what our patients tell us about neuropathic pain. We try to find these symptoms. It's not always easy to have these informations. We ask them if they feel electric shock sensations, burning sensations, pruritus, tingling, painful cold sensations, thermoalgic pain disorders, needle prick sensations, allodynia, and hypoesthesia. Well, these are not all the signs of neuropathic pain. These are the main ones. And when usually we take at least 30 to 1 hour consultation to explore the whole symptoms panel. The next, please. When we have difficulties to identify a neuropathic pain for small fibers, we can ask for another paraclinical explorations. I always like to confront the theory with the real-life data. The real-life elements, well, we can always ask for a skin biopsy. Usually it can take us a month to have the appointment, and usually it will take us 1 to 3 months to have the result. Especially if it's in the university hospital. We can ask for laser evoked potentials. Well, the medium range time to have an appointment is between 4 and 6 months. We can have a QSART. We have one practitioner that is able to do this exam. It takes us 3 months to have the appointment. We can use some interesting scores like the NES-LL score. It's not very adapted for common pain assessment and not easy to make. The DN4 score is not specific and always helpful. It needs a lot of rigor. It must be very rigorous to ask the good questions, to have the good assessment and the good examination. And we have also the Sudoscan. Now, would like to next slide, please. I'd like to tell you the difficulties from assessment to treatment in a chronic pain center. The ideal path to a performing treatment is an accurate evaluation. But in real life, the evaluation of neuropathic pain is not always obvious, and sometimes not always well conducted, even by pain practitioners. And as I said, we're not all very performant in neurology. So we have the scores, we have tools to evaluate it, but sometimes the evaluation of neuropathic pain is not well conducted. The patient is not always very precise in his own auto-evaluation because there are emotional and cognitive interferences. And that is our daily job in the pain centers, just to separate the emotional from the objective signs. The evaluation scales that are available are not always very accurately used. One of my former professors in pain management always told me that you have to use the proper tool for the right task. There's probably a scale for everything. The real problem is, are we using the good scale to measure the good symptom? And that is probably a very difficult question, because it's not just because the scale says it's not sufficient that the problem is not infraclinical. And at last, clinical examination is sometimes difficult to interpret, even when it is well conducted, because we don't have the experience of accurate and very sharp neurology. So sometimes we ask the help of our neurological colleagues. Next slide, please. So the problem that we have faced for years is that the more accurate the assessment is, the more you can fit the right key, which is the molecule, into the right padlock, which is the receptor. So it's not a standard treatment that we can give to a patient. We can use gabapentinoids, duloxetine, tricyclic antidepressants, and the list is very long, so I will not do in very precisely all the arsenal, the pharmacological arsenal that we have, but every key has a specific lock. So you have to really identify have a good assessment to be able to really fit the right molecule in the receptor. Next slide, please. In real life elements, also, chronic pain centers in France, this is one minute of a political stand, are really saturated, almost 1 to 120 pain centers. That allows us be able to see everybody, to have one visit per year for per patient, which is largely insufficient. So one visit per year, we need a reliable data for an accurate assessment. We need elements for the most possible early detections. We need painless and non-invasive explorers. So painless because we're in the pain center, we cannot have to add more sufferance to our patients. We needed also something without prior specific preparation, something that would go very fast. I told you about the delays to have these paraclinical exams. It needed to be a non-timing consuming exploration, and to have easy obtainable data for patients follow up on every consultation. And at last, which is something important in France, we needed something that would not be expensive for patients and especially for the hospital. Next slide, please. So we found in Sudoscan something that has matched absolutely our needs. The reliable data, the early detection elements, the painless and non-invasive exploration, the non-consuming exploration, the non-specific preparation, the easy obtainable data, and the non-expensive paraclinical exams. Next slide, please. So the Sudoscan is a very adapted tool that has matched our needs. The data can be obtained in 3 to 5 minutes during the consultation. It's easy to interpret with the color index. The green, we have a very easy interpretation with 3 colors. Green, which is normal, yellow, which is subnormal, and orange is abnormal. So it's really easy to explore and to have this very useful Sudoscan in our daily work. Although we had a relatively short experience with Sudoscan, I already told you that it was for 1.5 years, and because I have only 15 minutes for this presentation, I decided not to expose clinical cases, but to share with you some of our preliminary figures since we started using Sudoscan in our chronic pain center. We have submitted our patients during 6 months, which represents 400 and 37 new patients with neuropathic symptoms to a Sudoscan test. Almost 10% of our patients were not diagnosed because of very infraclinical symptoms and mild symptoms and non-significant scoring. 10% have been revealed as neuropathic pain. And that was very interesting. Also, we had followed up specifically patients with neuropathic diabetic pain and chemotherapy-induced pain. The transformation of the impedance status from abnormal to normal or subnormal was almost seen in 87% of these cases, which is significant to ensure the targeting of the ongoing medication and the symptomatic progress. I think that we will be able to analyze significantly a series of more than 1,000 patients in 6 months or so. That's why I would like to share just these preliminary figures, and hoping to soon be able to have an article with more data, more significant. Next slide, please. Anyway, we have a lot of articles going on that will allow us to be more and more accurate and more specific in the use. I don't think that in chronic pain we can have a direct link between a pathology and an interpretation. It's very soon for us in our center, just after 1.5 years, to be able in every situation just to be able to have something very significant for the moment. Next slide, please. Thank you.
I have a question, Dr. Mario. Based on your experience, what is the most common cause in France for after type 2 diabetes of painful neuropathy? What are the neurologic conditions that are more common in France, leading to painful neuropathy?
Well, I avoided to talk about fibromyalgia because the next lecture it will talk about it, but it's something really controversial for the moment. Well, I have a personal clinical impression that there's in fibromyalgia peripheral disorders in the small fibers neuropathy as much as a central thalamic disorder. But I voluntarily didn't talk about it. This is the big problem of the nociplastic, and this is one of the most situations that we would like to have a real review and study about.
Okay, thank you, doctor. There's a question if the results are quantitative. Yes, of course. So what Dr. Mario showed, the green area, it's when the results are over 70 on the feet. This is what we call green area. Between 70 and 50 is the moderate or early neuropathy, and below 50 is severe neuropathy. Thanks a lot again, Dr. Mario. Due to the lack of time, we will move to the next presentation. Next slide, please. So I will welcome now Dr. Bobby Varkey, that is a leading Indian neurologist and has a large experience with Sudoscan use at different healthcare settings in India. He is trained at the SCTI, MST, and Mayo Clinic, and he is specialized in critical care and interventional neurology. He is currently a leading consultant at Apollo and Lourdes hospitals with over 160 publications and fellowship from prestigious medical institutions. Certainly, the brilliant career of Dr. Varkey cannot be summarized in a few seconds, but let us move quickly to this presentations that we are all excited to hear. Next slide, please. So in his presentation, as mentioned at the beginning, Dr. Varkey will highlight the latest update, diagnostic and management criteria in addition to the role of Sudoscan in fibromyalgia. Dr. Varkey, please go ahead.
Thank you. Good afternoon, everybody, and a big thank you to Dr. Hanai and the Sudoscan team for having me here today. I've chosen fibromyalgia because it is a disease that treads on every specialty. We all have patients with chronic pain, unexplained symptoms, and many of these, when we started practicing neurology 20, 30 years ago, we didn't have a name for many of the myofascial pains and the unusual pain syndromes that used to come to us. But gradually we realized that a lot of these patients actually had fibromyalgia. Even after making a diagnosis of fibromyalgia, we could never come up with anything tangible or anything concrete to tell a patient that, look, we have such and such a test that is possible for us to say with a certain degree of certainty that you do have an organic problem. Because as you know, there is a lot of connotation in the general medical circles that fibromyalgia is mostly a disease of the mind. There's a lot of psychological component to it. And it would be really nice if we had something to show our patients that, look, understand the exact fibromyalgia yet. We might possibly be able to delve further into the etiology with current techniques and might be able to provide you a much better or targeted therapeutic course soon. So that is why I wanted to dovetail this whole concept of fibromyalgia and small fiber neuropathy and the use of Sudoscan in fibromyalgia today. Next slide, please. So first, I'll just start off with an outline of fibromyalgia. Next slide, please. Next slide, please. So as you all know, fibromyalgia is a symptom of persistent, widespread pain. Patients complain of fatigue, disrupted and underfreshened sleep. They have a lot of cognitive difficulties, especially what is called brain fog or fibro fog, which is a brain fog associated with fibromyalgia. And this is also accompanied with multiple other unexplained symptoms. Patients may have anxiety, depression, and other functional impairments of daily living. In general, most patients have multiple tender points of examination. They have widespread pain in more than 7 regions. They have pain which occurs on both sides of the body and occur both above and below the waist, as well as in the axial spine. They have plenty of stiffness. They have sleep disorders, cognitive disorders, anxiety, and as I said before, it actually affects the most of their daily activities. Next slide, please. So we'll go to the 2016 ACR diagnostic criteria, because I know that being busy practitioners, fibromyalgia is something that we tend to just diagnose offhand, and we really don't go back to look at what has evolved in the field of fibromyalgia and how things are moving in terms of elucidating the different diagnostic criteria and keeping up with the latest changes in fibromyalgia diagnosis and management. Next slide, please. So to put it in brief, you have either the widespread pain index or the symptom severity scale right now. So the widespread pain index is a 19-point score, graded from 0 to 19, and the symptom severity score is a 12-point score. And basically, you have to have a WPI score of greater than or equal to 7 and a symptom severity score of greater than or equal to 5 to qualify for fibromyalgia. Next slide, please. So this slide basically shows you some of the regions where if you press, the patient will exhibit tender points. These include the jaw, part of the neck, the shoulder, forearm, the wrist, part of the chest, paraspine, the axial spine, the region around the hip, the mid thigh, and the lower leg. And if you have pain in any of in more than 7 or 9 of these places, then you potentially have fibromyalgia. And you also can look at different symptoms of fibromyalgia, such as fatigue, brain fog, as well as widespread pain, depression, and headache. And you can score this, and based on this, you can arrive at a potential diagnosis of fibromyalgia. Next slide, please. So in addition to having a patient reported subjective score, you can also use your own, either your thumb to produce pressure enough to blanch the nail bed, which is equal to about 4 kilograms of pressure, or you can use an algometer, which provides a more graded pain or pressure stimulus. And you can use this algometer or your thumb to score the amount of pain at each site. And you can derive a sort of fibromyalgia intensity score, which will give you a standardized score and a standardized protocol by which to grade and to measure the response of fibromyalgia to treatment. Next slide, please. Next slide again. Now, fibromyalgia is long thought to be a centrally processed disorder. It is basically a disorder associated with central sensitization. But there are some recent studies based on corneal nerve fiber length and based on intraepidermal small fiber nerve fiber density, which show that about 30 to 50% of fibromyalgia patients may have a small neuropathy, and these patients who have these small fiber neuropathy or symptoms akin to small fiber neuropathy may have a greater mechanical pain sensitivity, depression, as well as anxiety and other psychological symptoms. Next slide, please. Next slide, please. But now, as you know, when a patient with fibromyalgia presents to you, you're bound to rule out or make usually diagnose fibromyalgia as a diagnosis of exclusion. So you are bound to do some basic blood tests, which include a complete blood count of differentials, metabolic panel, urinalysis, definitely work up for thyroid disorders, 25-hydroxy vitamin D. As you know, there's an epidemic of vitamin D deficiency because we've all become vampires now with no exposure to sunlight. Check vitamin B12 levels, iron studies, because subclinical iron deficiency is often produces the same kind of symptoms such as fibrofog, anxiety, sleeplessness, fatigue, hair loss, and a lot of these symptoms actually overlap with fibromyalgia, as well as check for magnesium levels and an ESR to make sure that you're not dealing with an underlying top. Shown to be about positive, about 50% of patients with fibromyalgia. But of late, much has been heard about this. So I'm assuming that since this test is still not widely available, that it is probably not of much sensitivity or specificity in the diagnosis of fibromyalgia. But still, it is a useful test to know that if this is available in your lab. Next slide, please. Next slide, please. Next slide, please. As you all know, the management of fibromyalgia is quite inadequate. It relies on a lot of non-pharmacotherapy as well as pharmacotherapy. Non-pharmacotherapy, generally you tell the patient to make sure they have a good diet, a non-inflammatory diet, supplement them with all sorts of vitamins, take care of the bone, and kind of encourage them to achieve weight loss, manage their stress, usually go into some sort of low-impact aerobic exercise, which either involves walking, running, water aerobics, water yoga, or stationary cycling. You ask them to sleep well, maintain good sleep hygiene, and also some patients can be referred to the psychologist for behavioral therapy as well as CBT, that's cognitive behavioral therapy. Next slide, please. Again, pharmacotherapy is quite inadequate. We have a wide stable of medications that we use for fibromyalgia, which mainly consists of anticonvulsants such as pregabalin, gabapentin, tiagabin, analgesics such as tramadol, anti-anxiety medications, skeletal muscle relaxants, antidepressants such as the tricyclic depressants or the SNRIs or SSRIs. And you may even use sleep medication for vitamin and mineral supplements or antioxidants in these patients. But as you know, even using all these medications, patients do not generally have a very great outcome with, or symptom relief in fibromyalgia. Next slide, please. Next slide. So up till now, fibromyalgia has mainly been thought to be a central sensitivity syndrome, in that there is some problem with the transmission of pain up the spinal cord into the thalamus and the cortex. And because it's a central sensitivity syndrome, it overlaps with many other disorders such as chronic fatigue syndrome, irritable bowel syndrome, chronic pelvic pain, temporomandibular joint pain, tension headaches, migraines, PTSD, etc. So this disorder can present to a wide variety of departments. So as a result of which, it's important that people know that even if you come in with some sort of a localized myofascial pain syndrome, if you refer to a department that has a Sudoscan available, you can possibly help the patient make out or help the patient see if there is some objective that can tell you that yes, there is something that can detect the presence of the myofascial. Next. Yeah. Decrease in the pain perception threshold. There are some sort of neurotransmitter disorders, neurotransmitter disturbances, and reduced discrimination of nociceptive stimulation from sensations such that patients experience dysesthesias, allodynia, and this may all be due to an altered functional connectivity and chemistry within the brain's processing system. Next slide, please. Now, another recent theory that's come up is that there's probably an increased muscle pressure within fibromyalgia, and the studies that have looked at the intramuscle pressure in the trapezius fibromyalgia patient in the trapezius is about 33 millimeters of mercury, compared to about 12 millimeters of mercury in patients with other rheumatic disorders, and a mechanism which explains the increased sensitivity or the tender points that are usually seen in myalgia and in fibromyalgia. And these studies have also shown that there is the higher muscle pressures are associated with increased pain levels in tenderness in fibromyalgia patients. And in addition to the central component, there is also a peripheral component to the pain that is experienced by them. So, as you know, when there is a localized compartment syndrome in muscle, this might lead to reduced blood flow, reduced oxygen delivery to muscles, ischemia, hypoxia, and English. Next slide. So, fibromyalgia is not a disorder in isolation, and it does not occur due to a single cause. It has a multifactorial etiology with environmental, genetic, biopsychosocial causes, and in addition to central sensitization and abnormal central nociceptive processing, there are a lot of other factors that we still have yet to figure out as to why patients with fibromyalgia go on to develop an intractable chronic pain syndrome. Next slide, please. So, some also shown that an autonomic small fiber pathology in fibromyalgia, because as I said before, a certain percentage of patients with fibromyalgia, the small fibers are affected. Although there is no correlation between the autonomic small fiber damage and the severity of autonomic symptoms, there is some correlation between the small fiber damage and the extent of pain or the symptom severity that patients in fibromyalgia experience. Next slide, please. Because of the high prevalence of small neuropathy in patients, small fiber in patients with fibromyalgia, we went ahead and conducted a small prospective observational study where we looked at about 56 patients with fibromyalgia, and we screened them out using a SIQ questionnaire and a small fiber questionnaire. Next slide, please. And we screened out about 56 patients with a mean duration of about 6 plus or minus 2.87 years. And we found that in these patients, when we did this symptom inventory questionnaire, which is a questionnaire that teases out small fiber neuropathy symptoms, out of 15, the mean score was about 8.6 plus or minus 2.4, suggesting that almost all patients who had fibromyalgia had an SFN-SI score of clinical presence of small fiber neuropathy. Small fiber neuropathy will have a role to play. So we subjected these patients to the Sudoscan with an equivalent control. First, the patients had an ESE score less than 60, suggestive of small fiber neuropathy. 2 patients had severely reduced ESE scores, and about 60% of patients, 50% of patients had fibromyalgia predominantly in the, neuropathy findings predominantly in the hands, and about 40% had SFN findings predominantly in the feet, suggesting that almost half of patients with fibromyalgia have underlying small fiber neuropathy, which can be demonstrated by a quick and easy test such as the Sudoscan. Next slide, please. So, so this was a small pilot study which is done by our neurology trainee, and her conclusions were that the evidence of a small fiber neuropathy can be detected by means of a Sudoscan in almost about 50% of patients with fibromyalgia, and Sudoscan, easy, non-invasive office screen, is useful in patients who come with myofascial pain syndromes and chronic pain syndromes. Of course, it needs validation for a much larger cohort, but preliminary data, the Sudoscan is a good diagnostic tool for fibromyalgia, small fiber neuropathy components. Next slide, please. So, being due to the fact that this Sudoscan, quite in many of our patients who come in with chronic pain, the best time to bring in these 2 disorders and show you all a novel use of the Sudoscan in a general neurology or a general medical field. Thank you very much.
Thanks a lot, Dr. Bobby, for this brilliant presentation and very instructive on fibromyalgia and the contribution of Sudoscan to evaluate the prevalence and severity of the small fiber neuropathy. That included also an overview of your preliminary results of the observational study. So thanks a lot for giving us the chance to have a look on this preliminary result. Hope they will be published soon. Quickly, do you have any question, 1 or 2 questions? We have exceeded our time, but does anyone have any question? Please go ahead, Dr. Manal, if you have any question.
Can I talk like speaking or writing?
Speaking, please, to Dr.
Yeah,
if you
okay.
have.
Okay. Actually, I have an opinion regarding the fibromyalgia, especially in the intractable cases. I do believe that if it is, and it is mostly like that, if it is associated with migraine, that patient is having migraine, then he got associating fibromyalgia, it will be so much intractable to treat fibromyalgia alone without looking and treating migraine with all the aspects, including the diet, lifestyle, and proper medication to reduce the burden of headache. Many people, they accept that fibromyalgia can cause headache as part of it. But actually, fibromyalgia is something in the muscles. So it can cause neck pain, but why headache also? Why do we accept? Why we don't separate? This is my question. I do believe that it could be 2 illnesses and we need to treat one because So most intractable migraine can cause more intractable fibromyalgia. I want to know the opinion of the doctor, please.
Yeah, thank you for your question. As you know, many of these disorders are comorbid conditions. Migraine also is a chronic, recurring, cyclical kind of chronic pain syndrome with a significant amount of trigeminal nociceptive activation, and it might just be lying somewhere on the spectrum of a central sensitization disorder or a central nociceptive processing disorder, because as you know, a migraine can be precipitated by sound, heat, light, loud noises, by intake of specific types of food which or interact with your gut, or with the absorption of certain types of say for example tryptamine or types of compounds from the intestine into the bloodstream, and it might be triggering of these central nociceptive processing pathways which cause migraine. So fibromyalgia is probably also pretty much very similar kind of, I would put it as a body migraine, because you know, I don't think it's a term. Understanding like a chronic migraine pain all over, because if you see a lot of patients with fibromyalgia actually come in with pain that spreads to one side of the body, and nobody has an explanation for that, but it might be in some way linked to both, which might be a reason why both are comorbid and coexist so frequently together.
Thank you. Thank you.
We can take one more question. Please, if anyone has any question, just activate your microphone and ask it directly to Dr. Barty.
Hi.
Hi.
Hi. My name is Geniel. I'm from Venezuela. My question is how this machine works detecting the small fibers. I know, for example, the electromyography detects the injury with the electrical impulse, right? But this machine, how it works?
Yeah, in fact, for the mechanism of Sudoscan, how it works, it will worth doing another talk about it to explain exactly how it's working, how we conduct the test, the pseudomotor function test. In fact, in a simple summary, we place hands and feet on, electrode sensor plates on the hands and feet, because here we have the higher density of sweaty glands. Then we apply low voltage potential to stimulate the cholinergic C fibers that are controlling sweaty glands. So depending if these fibers are healthy, we will have high release of chloride ions, high conductance. So the ESC will be over 70. When this cholinergic C fiber start to be damaged after the stimulation, we will start to see decrease in the ESC. So we consider that, according to our normative data, that below 70 is the early neuropathy and below 50 is a severe neuropathy. Anyway, we will send you some documentation detailing the mechanism aspect, and I hope in our future webinars to have like some slide on this exclusive. Sorry, we don't have more time. We have just already exceeded by like 70 minutes. Let's go to the conclusion. Please. Next slide. So nothing much to add on what have been like greatly presented today. So as you know, peripheral neuropathy is a multifaceted medical condition due to the metabolic and other neurologic conditions. And it can lead to diverse symptoms such as burning sensation, tingling, electric shock feelings, numbness. And this condition often undiagnosed or misdiagnosed and can lead to a poor quality of life. Unfortunately, despite the alarming prevalence and consequences, there exists a gap in its diagnosis and management. So in this clinical context, as presented by our speakers, Sudoscan offers advanced diagnostic capabilities with a higher sensitivity and specificity compared to conventional tests, and it's now becoming a reference test for small fiber neuropathy, widely endorsed with a lot of inclusion in many international recommendations and over 300 publications. Finally, thanks a lot again for our speakers, audience, doctors, and colleagues for joining us today, which wish to welcome you during our upcoming webinars.